Welcome to the latest ECIST podcast. Hello, my name is Pete Gordon. I'm Head of Emergency Care Improvement with ECIST, the Emergency Care Improvement Support Team, and today I'm joined by my colleague Ben. Ben, would you like to introduce yourself?
Yeah, hi Pete. Ben Owens. I am an ECIST Clinical Associate. I'm an ED consultant at Sherwood Forest.
Brilliant, thanks Ben. So we're going to talk about managing risk within the emergency department. So I guess the first question is, from your point of view, how do you manage risk within the emergency department, and how do you keep the emergency department as safe as you can?
It's about several things. It's not just the ED; it's the system, it's the ambulance service, the trust, and everyone together. It's about balancing risk. You've got to take risks sometimes to mitigate risk somewhere else. It's actually our greatest risk is at night. So the day team's job is to sort the evening team's job is to sort the shift to hand over to the night team. The night team is the most vulnerable time. That's our focus all the time. How do we keep that going? It's about internal professional standards and actually making sure everyone, including the ED team, are held to those in terms of timely care. And timely care really does matter in emergency care. It also affects crowding. It's about trying to get streaming right at the start. Getting people to the right place first time it is clearly better for them, but it's better for the other patients as well. Primary care services, ESTEC, post-op patients going to surgery, all those things makes the ED team time to do what they need to do to look after sick people. And it's about having your systems and processes and sticking to them and going back and checking. We're great at making plans sometimes. We're not always great at checking those plans are actually happening. And there's no point having a plan if it's not executed.
Thanks, Ben. Talk us through how you keep the emergency department safe overnight.
Yeah, it's about getting your processes right, replicating day processes in the evening, those being making sure your triage times on them, making sure you've got investigations treatment front loaded to all streams to your patients, making sure your time to your doctor is kept to a minimum, and making sure your decision making is there and repeated with huddles as you're going along. And what you do in the day and the evening is what happens to make your ED safe at night and what you hand over to them in terms of workload.
Brilliant, thanks Ben. And now Ben is going to talk us through the principles of managing risk in the emergency department.
Okay, so this is really the theory behind how do you manage risk in your ED in terms of crowding, but also how do you make your ED as safe as you can at night without changing staffing like that. With the resource we've got, the space we've got, how do you optimise the process of an ED to keep it safe at night. So in terms of occupancy and crowding, it's down to two things. It's about the time they spend with patients in the department and the number of patients that come through. And I represent this really in terms of 100% of your patients, not 50% patients there. So actually look at this, about most EDs will admit about 25% of your patients. So about 25% will get admitted. The other 75% will go home, and that represents them. Obviously the admission patients at the moment, for most places I can find my beds and crowding there. In terms of making majors safe at night and how we achieve that, this is over here. So most EDs, we staff our department. If this is midnight, that's 8 o'clock in the morning, that's 4 o'clock at night, and that's midnight again. And this is the patients or staff on duty at any given time. Most patients in most EDs follow the same profile. About 7 o'clock, people arrive like this. They come in, about 11 o'clock peak comes along, second peak about 5 or 6, 7 o'clock. It comes down like that. It tails off rapidly after midnight and does that overnight. That's your normal patient profile of arrivals. In terms of staffing, most places, staff on duty per hour, will staff the department with a number of staff on duty per hour roughly to match that. And you work on one patient per clinician per hour. And this is your staffing profile for the department. And you tend to have slightly more staff than patients overnight, but then nights is where most of your majors patients are, very few minors, primary care type patients, that sort of thing. Where does most of our risk sit in all of this? Well, actually, most of our risk sits at night. So this is where night time is where most of the risk sits here. The daytime is the least risky time. And then you've got the evening there, which is basically more risky than days. Still not so bad. The job of the day team is to hand over a decent waiting time to the night team. The job of the evening team, a decent waiting time for the night team. The night team's job is to survive till the morning. This model of staffing per patient arrival time is great until you've got a wait to be seen. If you've got a wait to be seen of 3 hours by the time it's 10 at night, the issue you then have is this. The profile of patients being seen is the ones that arrived 3 hours earlier. So that to be seen profile, now doing this. What you now have is this evening nighttime team with 3 hour wait. Your 7 o'clock peak arrivals being handled by your night team who arrive at 10 o'clock. We aren't staffed to do it. That's deficit. That really spills over though after midnight, and you get this deficit here. What often happens then is they start to struggle to cope, and that waiting time becomes a 5 hour wait at midnight. And a 5 hour wait at midnight looks something like that by the morning. It becomes a 6 or 7 hour wait in the morning, and this is the risk here. Most of these people are frail old people on ambulances. No one misses the rhesus patients, the sick ones, because they're really obvious they're septic. There's less sick who sit and wait. You've got more tired staff, you've got fewer senior staff, you've got less of the hospital to help you. All our risk sits here. How do we manage this? Going back to our occupancy theory, dead simple. A number of people in your ED will have primary care conditions, and most of these will have a primary care stream. For our own ED, it was 8%. We managed to push that and push this line across. So actually, it's much higher. So the higher percentage you push to primary care at all times a day will reduce the waiting time. Everyone in primary care staff sees you don't see, produces the waiting time for the next patient, which will ultimately reduce this waiting time at night and this risk here. So by streaming to primary care here, these patients are not in your department, but these ones still in your department are affected because the doctors are now free to the next patient. If these are your admitted patients and these are your discharge, this area is your discharged patients here, about 25% get admitted and about 75% go home. This is in the control of the organisation. This is in the control of the ED team to a large extent. So what can we do with this? Roughly half of our patients are majors, and about half of them are admitted, about half of them are minors or Peds or primary care. We send more to primary care. Actually, should be a higher portion of Peds go to primary care because nearly all children go home. We know that. If we do that, that will reduce our waiting time of those patients that are discharged because we see by a doctor quicker. So you'll reduce the occupancy by taking this out into primary care, but you also reduce the waiting time of this to a degree. There will be a number of people who are suitable for STEC. So you want to optimise your STEC pathways. And it's better for the people who are suitable for STEC are better seen by medics in STEC. People suitable for primary care are better seen by, if it's the right patients, are better seen by primary care patients. You're improving these patients' care, but in doing so, you reduce the waiting time further, and you'll take some more time off this group of discharged patients left in ED. If we're doing this, we've taken the occupancy from this area here, by primary care, to get to this area here. If you take these off, the occupancy is now this area here. So minors particularly is impacted, but majors is also made better by streaming out to primary care. Your internal professional standards should mean that people who return post-op, people who are GP referrals, whether specialty accepted or not, are best seen by that specialty, and that's the best patient pathway, always the best patient pathway. If we do that, there's fewer people for ED to see. The waiting time in ED will reduce further. There's also a few specific pathways you might have, like bleeding early pregnancies, very small number of these, which will also, that will have an impact there. So what we've done by streaming these ambulatory minors patients to the right place first time, it's not compromising their care. What we're actually doing then is we're freeing up staff to see the majors patients. So that's that part. We can actually impact the waiting time for the admitted patients by admission avoidance. If we use STEC and really optimise things like STEC, either by discharge, we make a different decision with our senior decision makers, but also by bringing, so if someone comes in at 10 at night and needs a transfusion, we can either admit them or we can send them home, bring them back to STEC at 8 the following morning and transfuse them then. By doing things like that, bringing jaundice patients back, bringing ambulatory pathways, everything, you can take some of these admitted patients away. If you take the admitted patients away there, they need to be admitted, a small percentage of them. What will happen then, of course, is the ones that do need a bed will get a bed sooner. So we can impact this to a degree, even though this is down to the trust. We can control this. Our occupancy has gone from this down to this, and all we've done in that, we've got the right patients to primary care, the right patients to STEC, the right patients to specialties first time, and the right patients on the right pathway thing. So how do we achieve that? How do we optimise that time-wise? In doing that, we look at the patient's journey. So we'll call it 4 hours for the sake of argument. So patients arrive at time 0. We aim for a triage or streaming time. That really should be 15 minutes. The reason for that is, one, safety. If someone is sick and there's a long wait for triage, that's a safety issue. But really, it's an occupancy crowding issue. If you have a 1 hour wait for triage and your STEC shuts at 6 o'clock, 7 o'clock, and it's 6:05 when the patients arrive, they'll miss the STEC cut-off. If your patients arrive at 6:05 and you've got a 15-minute wait for triage, what will actually happen then is there'll be an STEC by 6:20. So your opportunity to stream only diminishes as time goes on. So not only is it a safety issue, this is a crowding issue, which ultimately makes ED safer at night. So where can you stream to? All the things. You've got primary care, you've got STEC, you've got environmental professional standards, the specialties, etc., and you've got pathways. That's the first thing. If you stream early and think you get about, the second thing that needs to happen, the key thing for any patient's journey will be any investigations or treatment the patient might need. If someone arrives and they're in pain, you don't give painkillers to see a doctor at 2 hours, and the pain takes an hour to work, the earliest time to get that back pain out the door might be 3 hours. If you have painkillers on arrival, actually the doctor sees them at 2 hours, you can discharge them at 2 hours if their pain's controlled. So we can control our occupancy simply by getting this bit just after streaming and triage right, and saying any pain relief, any fluids, any antibiotics, any nebulizer for wheezy people, all those things will hopefully, for those that can go home, get them home earlier. For those that are coming in, it can only improve their care as well, so it's better for those. But crucially, it's part of your discharge cohort, 75% that we control, and this is probably 9% predictable in terms of treatment. Investigations are similar. Most of them are predictable on arrival, so your triage nurse x-raying for limb injuries, or some sort of process of ratting or senior streaming process where every patient has a senior review in majors. If you need an x-ray, or if you need blood, it takes about an hour. So bloods are done at half an hour, they'll be back at 1.5 hours. With bloods. We've got x-rays, if they're ordered at half an hour, and usually they're completed within an hour, as long as your processes are right, you get the result back at 1.5 hours. For CT, the key thing we tend to do, it's an hour to get the CT done, and probably an hour to get the CT reported by national standards, so really it's 1 hour, this is 2 hours. So if you are aiming to see a doctor within an hour, ideally on arrival. So if you've got no wait to be seen, don't triage, just send the doctor to see the patient. If the doctors are free and the ambulance crew arrives, get the doctor to take the crew off the ambulance crew. Any time wasted here makes the waiting time greater here at night, makes majors less safe at night. The crucial thing about this process here, and it should be 24 hours a day, not a process that works on rats open 8 till 10 o'clock. A 24-hour process that gets your CTs, x-rays, bloods done, and all treatments that are obvious done at the start. If you have a 3-hour wait to be seen, and you've had all this done, the patient's had a CT, then actually you can make your decision there, because treatments are being done, x-rays and bloods are done, the CT's done. If they're not, and you order a CT at 3 hours, you're looking at 5 hours for that CT result to make your decision. So by doing this right here, even with the 3-hour wait to see a doctor, you're making that patient a 3-hour stay rather than a 5-hour stay if they're a discharge. If they're an admission, and there are beds, and sometimes there's an exit block for medicine but not for surgery, and that CT is back quicker, then actually they can go to the ward here, not here if it's bed free. So we can take some time off our admission patients by getting our processes right in the ED. So we can further reduce the occupancy for the admissions as well as the discharges doing this. But the other crucial thing that needs to happen is so you have a streaming, you need to have investigations and treatment start as early as possible. We need to have, including a senior review for majors, we need to have a doctor see the patient or clinician see the patient, can be at the start. But if later on, if this is done, we minimise that occupancy delay. The final thing is decision making, and this is where huddles come in. So actually getting your senior doctors and your senior nurses together to huddle, chasing plans, checking things every 2 hours. If you do huddles here, and huddles here, even if a patient arrives here, within 2 hours, long as this has happened, you'll be fairly close to knowing what's going to happen to the patient. From a 3-hour delay, you can actually put a plan in advance. The other key thing about the huddles is not making sure the huddle just happens and we make a plan, it's actually making sure the plans actually happen. There's no point saying waiting for a CT and 3 hours later we're still waiting, the plan's not happening. Really important with that. Can this make a difference? If you see 300 patients a day through your department and you can take 20 minutes, only 20 minutes off their average length of stay, I defy any department to say they couldn't do that with process and refinement and internal professional standards, and that would save you 100 hours of occupancy. 100 hours of occupancy, that's 50% major, 50% minor, as we talked about earlier, that is 50 hours crucially, of major occupancy. That is 2 cubicles, free 24 hours a day, equivalent of, wouldn't be exactly that, but essentially that's it. From a staffing point of view, if you can stream another 15 to primary care, another 10 to STEC, and another 5 to specialties, which again most trials will be able to do, that's 30 patients. 30 patients is basically a 10% activity reduction. A 10% activity reduction would take it like taking a bad day into a good day into a great day. And finally, if you look at staffing and doctors, 30 patients in reality is probably like 3 to 4 junior doctors extra per day in a 24-hour period. So we went to any ED in the country and said, if we gave you 2 extra cubicles, a 10% workload reduction, or 3 to 4 extra docs on shift a day, would that make a difference? A massive difference. This doesn't actually cost anything. This is just about our processes and procedures. It's about consistency. It's about actually, most importantly, all of this is the right patient pathway. Why would you send a child to primary care when instead of 2 hour waiting in primary care because they're a primary care patient they can wait when you've got a short waiting time in ED at 4 o'clock? Well, actually, because it makes majors safe at night. Why do you internal professional standards in the daytime? Makes majors safe at night. Why do you pre-order X-rays, bloods, and things to do a RATIG or seniors teaming process, whatever it is? We do this to make majors safe at night. And if we do that, we follow that principle, and then we build our pathways off that, we can make the safest department we can, and the best we can, regardless of the situation, regardless of our staffing. If we don't have principles behind how we do this, how can we make a difference for our patients?
Thanks, Ben. That's fascinating stuff. Just one final question from me is, how do we get, this subject matter into the hands of lots more clinical folk, nurses, doctors, therapists, and operational managers? How do we get it into the hands of the many so people really understand about managing risk within emergency departments?
I mean, the aim of the game really is the doctors, nurses, therapists, people within the ED, but teams outside the ED. If they understand why we do what we do, they're much more likely to be engaged in doing it. And if we have a consistent thought process of everyone on shift, then we've got to give better care to our patients when we're doing that.
So that's the end of the podcast. Big thank you to Ben for that. That was fascinating stuff. And you can continue to see all our podcasts on our YouTube channel, which is on YouTube, and it's called ECIST 1. Thank you very much.